So thank you very much for this invitation to speak during this wonderful conference. And I would like to speak today about molecular testing and therapy in ovarian cancer, what has happened and what will likely happen in the future. First of all, I would like to go through some brief data. As you can see, ovarian cancer is a concerning disease because we have over 300,000 cases, new cases each year, and they are backed by more than 200,000 cases of death each year. So this means that we have a very high mortality to incidence ratio. So this means that we need to do more for these patients. And also it's important to see the fact that even if we are talking about developed countries or developing countries, we have similar trends in incidence and mortality. And it's important to know the fact that more than 85% of these cases are diagnosed in advanced stages. We are talking generally about high-grade serous cancers. So stage 3 and stage 4 is the bulk of patients we are treating. And as we can see from this survival curve, we can see that more than the median survival for stage 3 and stage 4 patients is roughly around 2 to 3 years. And it's important to know what Professor Dubois showed more than a decade ago, that our definition for surgical debulking should be complete surgical debulking with no residual tumor left. And this can only be achieved if we do this kind of surgeries in tertiary cancer centers and using extensive surgery techniques. And what I mean by tertiary cancer centers, I mean cancer centers that have more than 25 large surgical debulking surgeries per year. As we can see, this is already associated with a longer survival. This was shown by William Kleiby. And also regarding the impact of extensive surgery, we can see from this study from Memorial Sloan Kettering the fact that when they adopted their new trend of extensive surgery that included upper abdominal surgery back in 2010, this was already associated with an increase in overall survival. And this is the history of what has been done in ovarian cancer from a chemotherapy point of view. We can see that things didn't change so much since the 1990s until a few years ago, but this will be later in my talk. So we had the backbone of cisplatin and cyclophosphamide that was afterwards challenged by cisplatin and paclitaxel. Another study showed us that using more than 2 drug regimens is not bringing us a benefit in overall survival. If we are using triplets or if we are using doublets, sequential doublets, there's no benefit if we use high-dose chemotherapy. And the only thing that was marginally significant was in 2011 when we had a benefit from the addition of bevacizumab. And this is the natural history of ovarian cancer patients. We can see that from the time of recurrence when they have symptoms, usually after a progression-free interval of 12 to 18 months, we start to treat them with platinum or not, depending on the last platinum-free interval, and they have progressive shortenings of their progression-free survival, and this eventually leads up to an extensive intra-abdominal disease that will lead to occlusion and patient death. And the median survival for patients when they relapse is around 21 months until the final endpoint. Now, another important point in ovarian cancer is the use of neoadjuvant chemotherapy. And we had 2 studies done by Fergote in 2010 and Kehoe in 2015 that showed that if in advanced ovarian cancer we use primary debulking surgery or interval debulking surgery after neoadjuvant chemotherapy, we obtain similar survival outcomes. However, this has been recently challenged, and we have a TRUST trial that is currently ongoing, and we'll have results next year because the surgical quality from those 2 previous studies was challenged, and now they are doing this study in a similar fashion, but they are using only highly accredited centers that have a minimum of 36 radical upfront debulking surgeries per year. And we can see that the medical community has adopted neoadjuvant chemotherapy over the last decade because this has given the surgeon a better chance of obtaining complete surgical debulking, and especially because many patients, when they are diagnosed, they don't have they are not fit enough to undergo primary surgery. But is it surgery standard in all subtypes? We can see that from these survival curves, it depends a lot on histology, and not all histologies have the same clinical behavior. We can see that if we look on the red curve, the mucinous or the clear cell subtypes, they have a worse prognosis than serous or endometrioid cancer. So it's not one size fits all, and we should adapt depending on tumor biology. And this is the trend where we should think also about personalized surgery. For example, in high-grade serous cancers, we can think of using neoadjuvant chemotherapy. However, for low-grade endometrioid, low-grade serous, clear cell mucinous, either if it's infiltrative or expansive, we should not opt for neoadjuvant surgery, neoadjuvant chemotherapy, and instead go for primary surgery, because these tumor subtypes are not as chemoresponsive as the high-grade serous. So there is this controversy of using neoadjuvant chemotherapy also from another point of view. When we do prior prior chemotherapy surgery, so surgery prior to chemotherapy, we can pinpoint exactly where our tumor deposits are within the abdominal cavity. But if we do surgery after chemotherapy, this can sometimes be challenging, and it can be hard to identify small tumor deposits. And this is where we have a recent change. We have the folate receptor alpha, which is a biomarker in ovarian cancer, which is highly expressed in over 80% of cases. And this folate receptor alpha has been used in an innovative way in ovarian cancer from different points of view. First, we have imaging using radionuclides for folate receptor alpha. We can also use this for intraoperative imaging, and I will come back to this. We have antibodies that target folate receptor alpha. We have folate drug conjugates. We have antibody drug conjugates, which is mirvetuximab, and I will come back on this. We also have small molecules, and we also have developed targeted immunotherapy that targets cells that express folate receptor alpha on their surface. So this concept of near-infrared surgery, basically we inject a fluorescence dye which is linked to folic acid, so it will target cells that express folate receptor on their surface, so we can better visualize during surgery tumor deposits within the abdomen. And this is the evolution of near-infrared surgery. We had fluorescein first synthesized more than 200 years ago, and recently in 2021, FDA has approved a compound which is named pafolachianin or Cytalax for the use of identifying malignant peritoneal ovarian cancer lesions. And this is the study that led to this FDA approval, which was presented during ASCO 2021. We can see from the graph that we had in primary, if this compound was used during primary surgery, we had an additional 18% of lesions that were identified. And if we used this compound during interval debulking surgery, so after chemotherapy, we had 40% more lesions that were identified by the surgeon during his intervention. And things also changed dramatically regarding folate receptor alpha. This year, there was a special session that was announced in the last minute at ASCO in Chicago, and they showed on this phase 3 MIRASOL study, so we had patients that were platinum resistant, high grade, so patients with a very, very poor prognostic. This antibody drug conjugate that I was mentioning earlier, mirvetuximab soravtansine, which is basically using an antibody to target the folate receptor alpha, and it's linked with a chemotherapy agent. We can see that the median overall survival was prolonged for these patients from 12 months to 16 months, and this was highly significant, so it will probably enter our clinical practice soon. We also in our institution have an experience with near-infrared surgery. We also tried to develop special compounds that we could use during surgery. So we first used in humans, we used what was approved. We used an indocyanine green, and I hope it works. We have a small video here. So we can see that in near-infrared, we injected an indocyanine green, which helped us to identify the microvessel structure from the peritoneum, and we had whiter spots and darker spots. We found out, and we presented these results at ASCO, that the darker spots were basically deposits, deposits of cancer cells, of a few remaining cancer cells which were engulfed in a stromal fibrous tissue after neoadjuvant chemotherapy. And we found that darker spots usually contain about 40% cancer cells. And we also tried to develop novel compounds that could last in the circulation for a longer time, which first were injected into mice, and we will do compatibility studies to see if they can be extrapolated and administered to humans. So basically these were special compounds that had a dye linked to folate receptor, and it was engulfed in nanoalbumin, so we could make it last longer in the bloodstream. And we can see here we had mice with peritoneal carcinomatosis, and this drug was injected, and we had areas that were, some of them were more fluorescent than others. These are the publications I spoke about. So what has happened today and what we do today in ovarian cancer? Well, things have changed a lot. We divide patients now based on their molecular testing, and we have in the lower right a diagram of how ovarian cancer looks. Half of them are homologous recombination deficient negative. The other half, 48% more specific, is homologous recombination deficient positive. From these, 1/4 is BRCA mutant, and the other 1/4 is not BRCA mutant, but has similar molecular abnormalities that lead to this homologous recombination deficiency. So, for patients with BRCA mutation, we can see in the first line, if we give them olaparib, at 7 years, more than 67% of them are still alive. And if we give them, as it was in the SOLO2 trial, if we give them olaparib during second line, we can see that we have a median survival of over 50 months, which is basically unheard of for BRCA mutated patients. But we also have solutions for patients who are HRD positive, and if we give them in the first line olaparib plus bevacizumab, we also had an increase in the overall survival, which was highly significant. So basically for half of these patients which are HRD positive, we can dramatically increase their overall survival. But how have we managed this? Because we managed to answer a very hard question: how can you target a tumor suppressor dysfunction? So we have a patient with a BRCA mutation, but how do you target a gene that is absent? And this was possible because of the context, because of the concept of synthetic lethality. So synthetic lethality means that if you add up two sublethal effects in a cancer cells together, they can become lethal. So for example, this PARP inhibitor, olaparib, doesn't target BRCA mutation. Instead, it targets the base excision repair. But if we target base excision repair in a tumor cell that is homologous recombination proficient, then nothing happens. But if we target this base excision repair in a tumor that also has homologous recombination, then a single strand break will turn into a double strand break that cannot be repaired because we don't have homologous recombination working in these cancer cells, and this will lead to tumor selective cell death. And this is the current genetic testing recommendations for ovarian cancer. We should have a universal genetic counseling and universal germline testing. And also, some societies also recommend we should do somatic tumor testing, because we have some BRCA mutations that are found only in somatic or only in cancer tissue, but not in the germline. So we should also do somatic tumor testing for BRCA1, BRCA2, and also homologous recombination deficiency. So this leads the way towards personalized medicine. So doing a treatment which has benefit and doesn't bring additional toxicity, or if it brings additional toxicity, we should also have a benefit. And this treatment algorithm in ovarian cancer has changed a lot. So basically, if we have a patient which is BRCA mutated or has a homologous recombination deficiency positive, we should give PARP inhibitor, and we should also think if we should add to this bevacizumab depending on the expected clinical benefit. However, there are a lot of variations on this depending on each country's national reimbursement rules. So what is homologous recombination deficiency, and how can we test for it? There are three ways in which we can test for homologous recombination deficiency. We can test the genes that repair the DNA. This is the first way, going for etiology. The second one is to test for consequences, which is genomic scars or mutational signatures. And we are looking for three specific things within the DNA. There are three types of mutations: LOH, TI, and large-scale transitions. And we have two algorithms for this. There's the commercial Myriad Genetics, which uses all three of them, and we have the one that was developed by Roche, by Foundation Medicine, which uses only the first, which is loss of heterozygosity. And the third one, which is the most accurate, are functional assays. However, these have not been clinically implemented in the practical in the clinical setting because they are hard to do and require viable tumor cells. So as I said, we had Foundation Medicine, which was used in the Ariel trials with rucaparib, and we had this Myriad test, which was my choice, that was used for niraparib and for the PAOLA-1 study with olaparib. However, there are some limitations. So HRD positive means that we have a score of 42 or higher. But this score was developed on a retrospective analysis. We don't have an optimal threshold. What do we do with patients that have a score of 41? Do we consider them HRD positive or not? Up to 15% of cases cannot be analyzed because of poor tissue quality. And we should not forget the cost price. It is around 4,000 euros for the Myriad My Choice. And we have different tests. I said only about the Myriad and the Foundation Medicine, but there are a lot of tests that are available on the market, and some of them correlate their results only in 30% of cases, which means that we have a lot of heterogeneity when it comes to these tests and how they analyze homologous recombination deficiency. So if we bring good paraffin blocks, it's like good tissue, good Italian shoes, and we have conclusive results. But if we bring a paraffin block that has not been properly preserved, it's like those bad sneakers, and we cannot bring an interpretable result for our patient, and 15% of them are inconclusive, and basically they cannot benefit from this maintenance treatment with PARP inhibitors. And as I said, you can see there are a lot of homologous recombination tests available on the market. Some of them are commercial, some of them are academic. And ENGOT within Europe thought about doing alternatives for this Myriad My Choice. And the new test ideally should be available, should be cheap, should be simple, should have a low failure rate, and it should not only correlate with what Myriad has managed to show, but it should also be tested prospectively in a clinical trial. And so far we have 3 possible tests that are academic and could possibly replace Myriad. We have the Leuven test, we have the Geneva test, and we have the NOGO test that showed comparative results. So to make the story even complicated, we should not forget that ovarian cancer in a patient is not a single disease. We have spatial and temporal heterogeneity that happens in these patients. Not all metastases are the same, and they can also change by being influenced by the host immune microenvironment. And these changes will also reflect into the genomic signature of this patient. So if we have a HRD signature that was valid during diagnosis, maybe at recurrence we will have a different signature. So what we used previously is not anymore valid for that patient. So a solution for this would be to use plasma circulating tumor DNA. And circulating tumor DNA is more diverse than a single metastasis, and we can capture with this multiple metastatic sites within a single liquid biopsy we can do for that patient. So this is something promising, and there have also been commercial strategies that showed that if we use artificial intelligence only on hematoxylin eosin scanned slides, we can predict with very high accuracy if that patient is homologous recombination deficient or not. So future predictive biomarkers will combine not only the clinical features or not only the genomic features, we will also include immune signature and functional assays, so we could better differentiate which patients are optimal in receiving PARP inhibitors and which don't derive that benefit. And we should not this is my last message, we should not forget what this poster said during this ASCO conference that happened a few weeks ago. So treatment for ovarian cancer should be done by gynecologic oncologists. And doing treatment by specialized gynecologic oncologists, this was associated with higher rates of BRCA and HRD testing, and also was associated with higher use of frontline maintenance treatment with olaparib or other PARP inhibitors. And I thank you for your time.